Hello and welcome to another Piper Pod. Today we're going to continue with the reproductive system, and this time we're going to look at the female reproductive system. You'll notice that there are some distinct similarities between the male and the female reproductive systems, but you'll also find that the females are far more intricate, complicated, and, well, I believe, a lot more interesting as well. So we'll kick in with general anatomy of the female reproductive system and we'll go from there. So the anatomy aspect is similar to the males in the extent that it has both internal and external reproductive organs. Okay, the function of the female reproductive system is the same as the male. It's responsible for producing the gamete, in this case the ovum or the egg, responsible for producing the hormones associated with fertilisation and the production of the ovum. But on top of that, it's also responsible for providing the environment for fetal development and protection. Okay, so that's obviously the main difference. When we look into the actual anatomy, the internal structures consist of the ovary. So this is the main gonad of the female. Okay, like the testes in the male, the ovary is the main gonad that produces the main androgen or the main sex hormone, and also produces the gamete as well. From there we have uterine or fallopian tubes that attach, and then they connect to the uterus as well. Now we'll have a closer look at some of these structures as we go along, especially when we start looking at the formation of ovum and ovulation. Now, surrounding the particular main sex organs is we have a few protective structures. So the first one, if we look down, we have the cervix itself. So the cervix is the area at the base of the vagina, forms as a cap of the uterus. Now, the cervix has a few roles. Obviously, it helps keep fetal development inside the uterus when they actually are being formed. And during sexual stimulation, the cervix itself produces a mucus production that actually attracts and draws in semen itself. Okay, so it actually aids in that environment. So from there we have the main vaginal channel that is there to house the penis during intercourse, and then also perform a protective, quite acidic environment to keep the higher structures like the uterus, the fallopian tubes safe. Now we'll talk a little bit more about the dangers associated with some of the structures as we go along. We'll just leave that one as there. From there, that just takes care of the internal organs of the female reproductive system, and if you move to the external, we have the labia and the clitoris. So the clitoris itself is the female's erectile tissue. Okay, so it has erectile tissue, so during stimulation it's highly sensitive and it can enlarge as well. The labia majora and minor, there is protective skin folds that keep the vagina cavity safe, but they also have vestibules within them. Now the vestibules are responsible for producing lubricants to aid in intercourse. Okay, so that's the anatomy side of the house. From there, we'll look at the version of gamete production within the actual ovaries themselves. Now, unlike spermagenesis, oogenesis is, I believe, pretty damn fascinating. So, spermagenesis doesn't start until puberty kicks in. Okay, so there's absolutely nothing happening whatsoever until puberty kicks in. They actually don't even have the ability really to produce sperm, or there's no pre-work or anything like that beforehand. Whereas oogenesis, during fetal development, so whilst the female fetus is growing in the uterus, we actually start the formation of the ovum. Okay, so during fetal development, the first couple of phases of meiosis 1 begin to occur. Okay, so they start with a cell called oogonians, and they're specialized stem cells, if you will, that are found within the underdeveloped ovaries of the fetus. Okay, now by the time the fetus is finished, the onogoniums don't actually exist anymore. So they're now prophase meiosis 1 primary oocytes. Okay, and they sit in the ovaries themselves. Now, you know how people often say that they have all the eggs you're going to need right from birth? Well, this is what they're talking about. So the immature primary oocytes are found in the ovaries right after fetal development. So as soon as a female is born, they will have about 1 million immature primary oocytes sitting in the ovaries waiting for puberty to kick in order to fully mature and complete meiosis 1. So that's pretty cool. So from there, they sit dormant. About 10, 14 years, depending on the individual, they will sit completely dormant until the follicle stimulating hormone from the anterior pituitary gland is activated, and then they'll finish meiosis 1. At the end of meiosis 1, they produce a secondary oocyte with half the genetic material, and then they also produce what's known as a polar body. Now, the polar body is a leftover cytoplasm and leftover genetic material that they don't need. Now, from there, the polar bodies can produce additional polar bodies if they want to, but the polar bodies have no function in the cycle. They're broken down and absorbed by the body. Okay? But the secondary oocyte is what continues to go through the ovarian cycle that we'll look at in a little bit. And then once it's ovulated, it will go into the system. Now, if that secondary oocyte is not fertilized, then it will never finish meiosis 1. Okay, it will stop at the metaphase of meiosis 2, and it's only when it is fertilized with a sperm does it actually finish its meiosis 2. Okay, so again, quite unique. Okay, so from there, once fertilization occurs, it will produce another secondary polar body, and that has again leftover chromatids, leftover cytoplasm, genetic material that it doesn't need into the polar. And then with the ovum and the sperm combining, it will create a zygote. Okay, and the zygote is the viable fertilized ovum that can now multiply, and one day, if it gets proper implantation and everything goes right, it can grow into a baby. Okay, so like I said, oogenesis is way more complicated and a hell of a lot cooler than spermagenesis. We'll look at each one of these stages and sort of how the ovum forms and then puts into the place to get fertilized as well. So it is a full cycle, and they produce one viable every month. Okay, so you start with 1 million right at the start of the primary oocytes, but by the time puberty kicks in, a lot of those primary oocytes are broken down and used as material to produce to finish the actual meiosis. So by the end, you'll end up with about 300,000 primary oocytes or immature primary oocytes ready to go through the rest of meiosis 1, meiosis 2, fertilization from there. Now, 300,000 is not bad, considering if you're having an egg come out every month, ideally, you're going to end up needing, in about 40 years, you're going to end up needing about 500. So you've got a little bit of redundancy with your primary oocytes. During this slide, we're going to just have an overview of the main hormones involved in the actual menstrual and ovarian cycles. And then from there, we'll look at both those cycles in details and then draw connection to the two. Okay, so whilst this slide doesn't particularly show it, this whole process, like the male one, starts in the hypothalamus, okay, with the gonadotropic releasing hormone itself. Now that will stimulate the anterior pituitary gland, which in turn will stimulate the follicle stimulating hormone and the luteinizing hormone. Okay, the follicle stimulating hormone is what is responsible for starting those primary oocytes into finishing meiosis and actually becoming a viable ovum. That's what the follicle stimulating hormone does. Once we move down and the follicle starts to form and actually gets into development, that itself will release estrogen. Okay, and estrogen does a number of roles. It actually starts production or the preparation of the uterine wall, so it increases vascular production and it starts thickening the wall. On top of that, it turns off the follicle stimulating hormone. Okay, the reason it does that is because obviously it wants to make sure that additional follicles aren't being produced when the uterus is getting ready to receive one. So if it didn't turn off the follicle stimulating hormone, it will just keep producing ovum. And then all of a sudden you will have multiple ovums being released into a uterus that essentially isn't ready, or is over progesteronated, or whatever the case may be. So it has to inhibit the follicle stimulating hormone. When estrogen gets to its absolute peak, it actually stimulates the increase of the luteinizing hormone. So the luteinizing hormone is mostly involved in the actual ovulation. So during a time period known as a luteinizing surge, it will actually change the ovum that's being formed and cause it to ovulate out of the ovaries themselves. Okay, and then from there, the luteinizing hormone will actually start causing that capsule that just released the ovum to turn into what's known as a corpus luteum. Okay, that's where we actually get the name luteinizing hormones from, is because it produces this corpus luteum. Now, the corpus luteum is a very cool, timed or short-lived endocrine tissue that actually produces progesterone. Okay, so when it produces progesterone, as soon as that happens, progesterone turns off again follicle stimulating hormone and luteinizing hormone, because you want to stop that from occurring. Now that's initially, and we'll talk about some specific time periods later on, but that's generally what it does. On top of that, progesterone is what's known as your pregnancy hormone. So it's the one that will absolutely thicken and prepare the uterine wall for implantation of the actual fertilized egg. Okay, now if, in this case, we'll say that fertilization does not occur, okay, so there is no fertilization occurring, therefore luteinizing hormones is turned off, which causes the corpus luteum to degrade, which means less progesterone is produced because there's no forming ovum within the ovaries. Estrogen levels reduce as well, and with the reduction of estrogen and progesterone, the lining of the uterus actually starts to degrade and then breaks down. Okay. Now there's two other hormones that the corpus luteum produce. One is during fertilization, which is a hormone called relaxin, and one which is turns off your estrogen production, which is called your inhibib as well. So there's some two other ones that it produces. So that's an overview of the hormones. And now I understand if it's a little bit confusing at this stage. I just wanted to introduce the concepts of the hormones before we move on to the specifics of ovarian versus menstrual cycle itself. Now, I will mention that estrogen itself is the primary sex hormone within the body. So it doesn't really evolve. It's a constant level, and during puberty it peaks because this hormone is responsible for your secondary female characteristics. Okay, it's also the one responsible for muscle and bone development and also body hair development as well. Okay, so hyperestrogenic states will actually cause females to be quite large basically and have body hair as well. Same too as when the estrogen levels get quite low, like during menopause, then you can start having pattern baldness and things like that. And I don't want to scare any of the young ladies listening, but that's essentially what our estrogen does. And progesterone only comes in during certain stages of our menstrual cycle. Your menstrual cycle, I keep saying ours for some reason, I'm not really sure why, but your menstrual cycle, and then from there will only be sustained in the presence of actual implantation and fetal development. Okay, now, like the testicles, this sequence of hypothalamus, pituitary, ovaries is on an axis as well. Okay, now, because the hypothalamus and the anterior pituitary are responsible for a lot of body functions, gives rise to the reasons around why exercise, stress, change in diet, change in environments can have an effect on menstrual cycles themselves. Okay, because it's to do with a miscommunication or a redirection of the hypothalamus pituitary ovarian axis. Okay, so it's all linked together. Nothing in the body works in isolation that I can think of off the top of my head right now. Okay, a closer look, basically to break down the things that we've already looked at into the cycles of ovulation. So look right back at the start, we have those primordial follicles. Okay, what is the start of our prophase of our meiosis 1. Okay, so they're sitting there. Now, in order to turn from a primordial follicle into a primary follicles, is actually a process that can take close to a year to occur. Okay, so in the background, there's a number of follicles that are being formed, ready to go. Okay, and it's actually used as a diagnostic side of the house. And if you have more than 11 follicles that are formed within the ovary at one time, then it gives rise to thinking or moving towards a diagnosis for polycystic ovarian syndrome. Okay, and on top of that, it usually comes with an androgenic state. Okay, so hyperandrogenic state, which gives you those features that I talked about before. Okay, but I digress. So it can take a year. So we want some of these ones in the background ready to go. So when the actual follicle stimulating hormone is released cyclically every month during your menstrual cycle, then we can actually start the formation of the oocytes and the secondary follicles. From there, as it moves around closer to the 10 to 14 day mark, we have a vesicle follicle, okay, which is oocyte surrounded by fluid. So a garafin is what it's called. Okay, now this garafin will stimulate the increase of our luteinizing hormone with the help of the estrogen that's being produced. It will increase the luteinizing hormone and we'll get a luteinizing surge. And then it will cause ovulation. Okay, so the actual luteinizing surge causes ovulation. Now this ovulation aspects can be felt by certain females, okay, and it's a condition known as mitral smirts, just to let you know. And the ovulation will essentially go out and the ovum will now be out of the ovary into the actual reproductive area. The leftover destructed capsule will then develop into a corpus luteum from the help of the luteinizing hormone, and then produce progesterone in order to thicken the uterine wall, ready for implantation. Nice and simple. That's what it does. Okay, now what a lot of people don't understand is the ovaries are not connected to their actual tubule bodies. Okay, so the actual uterine tubules or the fallopian tubes are not really connected to the uterine body. So when we have a look at that closer, okay, we have the uterine body, which is made up of 4 specialized areas. Okay, and the main one right at the end is the fundula. Okay, so long stretched out collecting hairs, okay, that are barely connected, or if not connected, to the ovaries themselves. So the ovary can release the ovum at any particular spot around the ovary itself. Okay, it doesn't have a preordained position. Okay, sometimes follicle development travels around the ovary a number of times before ovulation occurs. Now from there, the interfundibles will create a current within the interstitial fluid. Okay, and that current is supposed to pick up the ovary and draw it towards itself in order for it to catch to the interfundibles and then get pushed into the uterine tubes. Okay, but quite often, okay, believe it or not, quite often the actual ovum itself will go out into the body cavity. Okay, and that obviously increases the risk of ectopic pregnancies outside of the fallopian tube and outside of the uterus as well, obviously. Okay, so it's actually quite a risk. Okay, realistically, it's quite a flaw within its design because it allows for ectopic pregnancies to occur, okay, even outside of the fallopian tube, which I agree is the most common, but it still can happen. And it also gives higher probability for things like pelvic inflammatory disease, because a vaginal infection becoming a uterine infection can infect the uterine tubes and then have free access into the actual abdominal cavity. Okay, so it can cause a lot of problems with females, and pelvic inflammatory disease is a very, very nasty disorder that has been closely linked to infertility as well. So it's definitely something to note, that's for sure. From there, I just wanted to point out that this structures exist, because it doesn't often get pointed out that this is a reality. Now, if the ovum is pushed away, the actual outside of the fallopian tubes themselves, then the menstruation cycle is still going to continue, because the corpus luteum is still producing that progesterone, so it's still thickening the lining. It will eventually die out because it's not getting any feedback of implantation, and therefore you'll go through your menstrual cycle and be none the wiser. Okay, but it increases the risk if fertilisation occurs outside of that uterus. Now, as far as what happens to that ovum that's found in your body, well, it essentially just gets broken down and reabsorbed by the body. Okay, so that itself doesn't cause any problems, but it's the outside uterine pregnancy that is the one to look out for. Okay, the old menstrual cycle is what we'll finish off. So everything I'm talking about here is obviously in the presence of, well, I should say in the absence of fertilisation itself. So this is what happens when fertilisation and fetal development doesn't occur. Okay, the next lesson we'll look at what happens when an actual baby is created. Now, the menstrual cycle, as you can see, it's written here as a 28-day cycle, but anyone who is a female or anyone that knows a female knows that this is not an absolute. Okay, so there's not a preordained must amount of time. This is essentially based on generally what can happen, or an average, or an ideal based on hormones and how long things take to produce, that sort of thing. Okay, so it can range. The range itself is even a little bit loose, but it can range anywhere between 21 to 42 days. Your cycle can actually wait. But the cycle starts the first day of menstruation. Okay, the first day of menstruation is when the cycle starts. And the proliferation stage is the first day that menstruation finishes. And then by the time we move into the excretory phase, we're looking at the day after ovulation. Okay, and that's usually the best way to think of it. Now, the time differences that can change the most is usually the proliferation phase. Okay, so how long it takes for that ovary to produce the ovum before ovulation occurs. Generally speaking, the secretory phase afterwards, so the progression from the ovulation to increasing progesterone to the breakdown of the corpus luteum, is generally around the same, about 2 weeks, okay, 14, 15 days. Okay, so after ovulation, generally 2 weeks after that, you will start menstruation again. Okay, but obviously the timings can vary. So during the proliferative phase, this is where estrogen is being produced by the developing ovum. Okay, once ovulation occurs and we start moving into our corpus luteum, then progesterone comes along and helps out with the estrogen as well, which thickens the lining, and then you move on to your menstruation. Once you no longer get the feedback from progesterone or estrogen levels, it turns off and menstruation will start. And that's the entire menstrual cycle as well. Okay, we can do it relatively quickly because we've already talked about the other things. Okay, so bringing it all together. Okay, nice and simply bringing it all together. Now, this is as easy as we can make it, and obviously there's a lot more that can be looked into from this, but this is generally the way that the ovarian and the menstrual cycles work together. Okay, so as I mentioned, all things start in the hypothalamus with the gonadotrophic releasing hormone. It stimulates the release of follicle stimulating and luteinizing hormone. Follicle stimulating hormone is responsible for the production of follicles within the ovaries, which produces a viable ovum and releases estrogen. Easy done. From there, once we have a viable ovum, estrogen causes the luteinizing hormone to increase. And when you get that luteinizing surge, you get ovulation and corpus luteum production. With corpus luteum production, we finally have endocrine tissues that can increase the amount of progesterone that is produced. Then, in the absence of any feedback, like implantation, the corpus luteum will decrease. The follicles themselves size will decrease, and therefore the level of estrogen and progesterone will drop, causing the thinning and the falling out of the uterine lining, known as menstruation. Okay, I hope you got something out of the female reproductive system. Like I mentioned, a little bit more complex, a lot more interesting than the male. Next lesson, part 3, we're actually going to look at what happens in the case that fertilisation and implantation is successful. So until next time, take care.